Thanks, Wells. I've opted to organize this talk by disease rather than pathway, and I was given the daunting task to review the HER family receptors and how we apply treatments to all GI malignancies. These are my disclosures. So as we all know, certainly attending this meeting, that GI cancers account for a huge proportion of oncologic practice. 25% of cancers are GI malignancies with a high fatality rate of 50%. And when we start with colorectal cancer, we're still dealing with about a 36% fatality, and we go up and down the GI tract. Pancreatic cancer is still 85%. HCC, which is an emerging, really epidemic disease based on hepatitis C. And this is a male-predominant disease, and we continue to see rises not only in HCC, but also esophageal and GE junction adenocarcinomas. So the HER family is an important group of transmembrane receptors where we have an extracellular domain which binds a ligand. The HER1 receptor is EGFR. HER2 we know targeted in breast and gastric cancer. HER2 does not require a ligand to bind. Basically, HER3 binds the ligand and it partners with HER2. And we know that dimerization of the receptors results in activation of the tyrosine kinase, and then we get intracellular signaling. So it's been mentioned over and over about the importance of RAS mutations, particularly in colorectal cancer, downstream from the EGFR pathway. Again, I'll emphasize again that we should not limit RAS testing just to the exon 2 mutations. And this is really a key pathway that determines the efficacy or lack of efficacy of EGFR-targeted antibodies in colorectal cancer. So really just to avoid duplication, this is just a summary slide of how we apply EGFR agents in advanced colorectal cancer. We really limit this to RAS wild-type patients. We now have the availability of two antibodies first line, either cetuximab or panitumumab combined with FOLFIRI or FOLFOX. And again, as I mentioned earlier, we probably should avoid capecitabine to combine with these drugs given the cutaneous toxicity and the data that suggests that capecitabine combinations with these agents actually do not lead to benefit. And then these drugs are also active in later line of therapy, cetuximab and panitumumab as monotherapy, and a suggested added benefit when combined with irinotecan second line. And we do, although there is marginal benefit, we still do consider treating the BRAF mutant patients with EGFR therapies. And again, this slide just emphasizes the need to test all RAS mutations. These are data from the panitumumab. Oh, this is the FOLFOX. This should be panitumumab here. The panitumumab study published by Doyard recently. And here we see the benefit for non-mutated exon KRAS 2 patients, so a survival benefit with the addition of panitumumab, where actually we got a detriment in the exon 2 mutation patients. So then if we apply this to the other RAS mutations, we see again this deleterious impact. So even in the other RAS mutated patients, using panitumumab in these patients has a detriment. So clearly, we should apply RAS testing to all RAS mutations, and we should exclude these patients from EGFR therapy. So what about a head-to-head comparison? In KRAS wild-type patients, we await presentation at ASCO, upcoming by Alan Vanuk of CLGB 80405, which will look at RAS-mutated patients, really the KRAS-mutated patients, because the data for the all RAS patients really came after this study was conducted, looking at first-line chemotherapy with either bevacizumab versus cetuximab. And I think this will maybe clarify some of the smoke that the FIRE trial has generated and give us a better idea how to apply these data to clinical practice. So what about the HER family in pancreatic cancer? There have been studies both targeting HER1 and HER2. This is the erlotinib trial, which is the EGFR tyrosine kinase, 560 patients with metastatic pancreatic cancer, gemcitabine erlotinib versus gemcitabine placebo. And then the infamous survival curve, which many of us were not too impressed with. Certainly the median, very minimally different, but the hazard ratio was 0.82. and the 1-year survival did achieve about a 6% improvement. So a marginal impact of erlotinib added to gemcitabine in metastatic pancreatic cancer. What about cetuximab? This is the SWOG trial. This was a flatly negative trial, gem versus cetuximab. So we have marginal data for erlotinib and negative data for cetuximab. What about HER2 in pancreatic cancer? There actually are some phase 2 data which did not lead to further study. One was a European trial looking at capecitabine plus trastuzumab, and this looked at high expressors with immuno 3+, and really not any signal of any benefit. Median survival of about 7 months. And then the group at Brown, led by Howard Safran, looked at gemcitabine plus trastuzumab in 34 patients. Most had a relatively low expression, 2+, but again, no clear signal. This looks just like gemcitabine with a survival of 7 months and a response of 6%. So these data have not led to further study of HER2-targeted treatments in pancreatic cancer. So what about HCC? Just to cover all the GI tract sites, we know sorafenib is the standard of care in advanced disease based on both the SHARP and Asia-Pacific data. Modest improvements in survival with a hazard ratio of about 0.7, and this has become the care standard. I'm just going to mention one trial of an EGFR-targeted agent. This was a large randomized trial in 720 patients of sorafenib placebo versus sorafenib erlotinib. So if you want data about EGFR, this was a negative study. No clear benefit for adding this agent. There was some interest about combining erlotinib with bevacizumab, but we'll have to await the final data, but I believe that's also been disappointing. So for the interest of time, I'm just going to mention this large negative trial of an EGFR-targeted tyrosine kinase. So now moving on to the area that's closest to my heart, esophagogastric cancer. In terms of trying to sort out why targeted agents work or not work, we really need to look at the genomics. And these are data from the Adam Bass group from the TCGA project. And it really appears in esophagogastric cancer that it's gene amplification, not mutation so much, but gene amplification, that's the driver in esophagogastric cancer. If we look at 300 esophagogastric cancers and nearly 200 colon cancers, colon in the blue, esophagus gastric in the red and yellow, we can see that amplifications and multi-copy amplifications are much more common in esophagogastric cancer than colon cancer. And here are 4 of the most amplified areas, and these include 2 members of the HER family. So HER2 amplified, EGFR amplified, MET, and FGF. So these are all targetable receptors and receptor tyrosine kinases. And there's a very similar study that was reported from China that shows the same 4 pathways that are amplified. So these are all potentially targetable. So does EGFR-targeted therapy work? You'd say, well, it should, because the gene is amplified in a number of patients. EGFR is overexpressed in about 80%, but the trials have been flatly negative across the board. Panitumumab plus ECX, actually giving panitumumab to patients worsened outcome compared to chemotherapy alone. The EXPAND trial, cetuximab plus CAPE-CIS, also a negative trial. What about a tyrosine kinase inhibitor? The COG trial from Great Britain, despite a lot of smoke and mirrors from the presenters on the podium, this was a negative trial. And the problem is that none of these studies used a biomarker or attempted to identify one. So these were not biomarker-selected patients, but the first foray, and this involves treating almost 2,000 patients, probably more than 2,000 patients, no benefit for EGFR agents. So here's the EXPAND trial, CAPE-CIS with or without cetuximab, really no difference in overall survival or PFS. And the REAL-3 trial, I found it interesting when they presented these data. It didn't appear that they actually had an interim analysis. They were having like sort of this holiday retreat at a beach resort, and they looked at the data on the first 650 patients, and they shrieked and they closed the study. So because this is what they saw, the panitumumab arm actually did worse than chemotherapy alone. Progression-free survival also trended worse. So this clearly another negative trial in advanced disease. What about combining EGFR agents in chemoradiation? You know, we have interesting data from head and neck cancer. We often think that we can apply these treatments to esophageal, at least to squamous cancers, but there are two negative trials. One is the SCOPE trial. This treated mostly squames, but some adenos, chemoradiation with or without cetuximab. And this trial, actually, the cetuximab patients did worse than the chemoradiation alone. And here's the RTOG trial looking at overall survival with no benefit with or without cetuximab and no difference by histology. And then here's the COG trial, 766 patients, best supportive care versus gefitinib. This was another flatly negative study. So again, no biomarkers, no patient selection, treating all comers, but certainly has not engendered a lot of interest in studying these drugs. But again, remember, it's a pathway that's amplified and it's a protein that's overexpressed in about 80% of patients. So I think apropos of the earlier discussions, we probably need to look at rescue pathways and crosstalk that we probably don't just need to target EGFR. We need to look at other pathways or downstream pathways to optimally potentially target this pathway. Now, HER2 has been the success story in esophagogastric cancer. We all know the TOGA trial, nearly 4,000 patients screened to identify 600 HER2 positive, comparing CAPE-CIS with or without trastuzumab. Summarizing the endpoints, everything was improved with trastuzumab, overall survival, progression-free survival, and response rates. So this is the one targeted agent now that's approved in HER2 positive disease. However, that doesn't mean that all HER2 targeted agents work. Tyrosine kinase inhibitors have failed. These are the two lapatinib studies. One is the LOGIC trial. This was presented by Randy Hecht at ASCO last year. CAPOX with or without lapatinib. This was a negative trial for overall survival. And interestingly, in Asian patients, there was a benefit. Because we saw data earlier that the VEGF studies, there was no benefit for Asian patients, but Western patients did better. But with lapatinib, it was the other way around. The Asian patients benefited and the Western patients didn't. Likewise, a negative trial of second-line lapatinib plus paclitaxel. The problem with this study, and we'll talk about this more in detail during the HER2 lecture, was patient selection. And we'll also talk about the novel HER2 targeted agents in development, which include TDM1, second line, and upfront combination of pertuzumab and trastuzumab in first-line therapy. And this is just a summary slide of some of the ongoing trials. We have HER2 targeted agents, pertuzumab first line. There's also an interesting trial, trastuzumab Heloise, which is looking at two different dose levels of trastuzumab first line. There still is an ongoing panitumumab trial in esophageal squamous cancers in Europe, a 300-patient trial. We talked about TDM1, which is the second-line conjugate HER2 drug. There's also another EGFR antibody being looked at in Asia. This is nimatuzumab, which is being looked at second-line in gastric cancer, irinotecan plus or minus nimatumumab. I wouldn't hold my breath based on the negative results from all the other EGFR agents. And then downstream, we have an ongoing study of everolimus, paclitaxel plus or minus everolimus. So then just to wrap up this whirlwind, her family tour of the GI tract, I think the take-home message is we need biomarkers to identify responding patients. The only successful trial to date in this family has been in HER2 positive enriched populations. For colorectal cancer, EGFR antibodies have a proven role in first, second, and third line. I can't emphasize enough that we have to expand RAS testing to all RAS mutations. For pancreatic cancer, we have a marginal benefit for erlotinib, negative trials for cetuximab, and negative exploratory trials for trastuzumab. For HCC, the only trial that I can quote here is the large negative trial combining erlotinib with sorafenib. In esophagogastric cancer, I think the key is going to be looking at the amplified genes. EGFR, despite the fact that it is an amplified gene, a number of negative studies that weren't biomarker-driven. Trastuzumab improves outcome and is approved, but lapatinib failed, and we await results of the ongoing studies of newer HER2 agents. Thanks very much.